in renewing for last 14 years, over 150 publications with 10,000 citations, and his current H index is 58. And then one of the most unique things about Dr. Gordon is that he's not only very good at the science that he does, but he's an exceptional mentor. And the reason I say that is a number of years ago when I was having a conversation with Dr. Gordon, he mentioned that he trains his students to be his living legacy and carry on the work that he does. So in that regard, he has been extremely successful in training a number of scientists in his lab. Several of them have gone on to have their own independent positions at tenure track institutions. They've had KO1s with Dr. Gordon, and some of them also have their own current RO1s. So it speaks to his mentoring. And one other thing that I really find unique about Dr. Gordon is that he has done a marvelous job of setting up a successful partnership between his research and the outreach. So one thing I didn't mention is that he's also the director of the Center for Cerebral Palsy at the university, and every summer he runs a summer day camp for children who have CP, and he provides, in this day camp they do intensive rehab training, which forms a main pillar of his research program. So I'm very happy to have you here. Please join me in welcoming Dr. Gordon.
Thank you, Neha. First of all, can everybody hear me? If you can't at any point, just raise your hand and I'll fight that. You set the bar pretty high for me here in the introduction, but thank you. It's a pleasure to be here. So I was being a little bit facetious with the title, but the point I wanted to make is that, as an exercise science department, that we do some foundational work that connects really well and has an important influence on rehabilitation. And I think actually that can be tighter, but I'm going to show you some of the ways that has happened. My work spans from basic motor control to clinical rehabilitation. So my basic motor control focuses on systems neurosciences as related to motor learning and control. So we're looking at the neural basis of movement representations and object representations that we manipulate, and sensory motor transformations underlying grasp control. I use that, so this is the work that's largely been funded by the National Science Foundation that Neha referred to. And this provides the basis to begin to think about mechanistic questions in movement disorders. Basically thinking about, what are the underlying causes of a particular movement disorder. And the majority of my work over the last 15 or 20 years has really focused on cerebral palsy. So basically, in typical and atypical developing populations, we look at the neural mechanisms underlying these movement disorders, sensory motor control, motor planning, individuation, and importantly, motor learning, which I'll come back to. And then this basically is parlayed into the development and testing of rehabilitation protocols, basically trying to increase evidence-based practice, looking at the role of treatment intensity, looking at dosing, ingredients of training, particularly motor learning, and plasticity associated with training, treatment specificities, and the neurocorrelates of the rehabilitation that we are doing. So I'm primarily going to focus on the latter part here, but I'll kind of tell you the story about how we got to that. So CP, I don't know how familiar you are with it. It is the most common pediatric neurological and physical disability. It affects about 750,000 Americans. Basically, it describes a group of permanent disorders related to the development of movement and posture. Okay, so it's very heterogeneous, many different forms, but basically the commonality is that it results in impaired movement to the extent that it can influence their participation in daily function. So they're often, the motor disturbances or disorder is associated often with cognitive, sensory, perception and sometimes by secondary aspects like epilepsy and musculoskeletal orthopedic problems. And the reality is that even though the disorder, so this happens very early during development, typically in utero or during the first year of life. It's an insult to the developing nervous system. And we think of it as a static disorder. Like you can think of it almost like a stroke that happens at a very, very early age. Stroke is one of the main causes of CP in that age group. But the reality is that the expression of the impairments and the expression of the disability changes throughout the development and throughout the lifespan, depending upon all aspects of what the individual is doing, play, work, and as they get older and they have to maintain body, support their body weight and so forth, the way that the various impairments might manifest may change. So it's not really static per se. So as I said, it's pretty high prevalence, about 1.5 to 4 incidences per 1,000 children born in the U.S. with a lifetime cost approaching $1 million in healthcare. That's basically an old number, but it's probably higher than that. So there are several types of cerebral palsy. The most common type, and where most of the work has been done, is hemiplegia, or unilateral cerebral palsy, where the weakness and impairments are largely lateralized to one side of the body. So basically, they walk for the most part, 99% of them. They will walk, very few are in a wheelchair. But they have impairments in their upper extremity that I'm going to come back to. Diplegia is the second most common. Basically, the lower extremities are affected to a much larger extent than the upper extremities. Not to say that there is no upper extremity impairments, but these are largely characterized by the idea that they're going to need some type of, they'll be able to walk in most cases, but they're going to need some type of support, assistive device. And then quadriplegia, affecting all 4 upper extremities, basically with a large proportion of them being wheelchair users. Okay. So I'm going to focus on unilateral CP to start, hemiplegia. So as I said, one side of the body and hand function is affected to a greater extent in the lower extremity. And as they age, they often fail to develop good motor skills that will affect their ability to play and especially their functional independence. It affects the ability to perform activities of daily living. So we've been studying hand function in hemiplegia now for many years, and we and others have figured out a lot of the contributions to the deficit. So sensory impairments is a given. I think this is an underappreciated aspect, but a lot of these children basically have impairments in their ability to sense proprioception or tactile sensation. What you most obviously see is impaired movement execution, muscle weakness, and basically an inability to perform movements in a very clear way, very easy way. So the execution, the motor impairment itself, is largely related to the dexterity of the corticospinal tract. Okay, so the corticospinal tract is the main and the direct pathway that goes from the motor cortex. Basically, it'll cross over at the level of the medulla and connect to the hand muscles on the opposite side of the body. Okay, so there are direct connections. They're extremely important for fine dexterous movements, object manipulation, for example, and damage to them will cause deficits in that. So if there's damage to the motor cortex, or if there's damage in subcortical areas that influence this, these are going to impact the dexterity. So this can be characterized in a very simple way by looking at the asymmetry in the cerebral peduncles here. Basically, so normally this would be somebody who is relatively mild, somewhat similar, and then here you can see a great asymmetry. And this is an area where the corticospinal tract passes through. So just from a simple MRI, you can get some sense of the corticospinal tract damage. You can do, even at the same level, you could use a diffuser tensor imaging, a technique to quantify the integrity of the tracts at different levels. And basically, it turns out that this damage relates very closely to hand function. So this was a study done in Belgium showing manual dexterity, basically a box and blocks, how quickly you can move these little blocks from one side of a box to another. Digital dexterity, basically it's a modified Purdue peg test, and then kind of a questionnaire of overall hand function. And you can see that there's a moderate correlation between the integrity of the corticospinal tract and their manual dexterity. But it turns out it's not quite as simple as that. So the development, so I mentioned that the corticospinal tract typically is crossed. So right brain controls left hand. So we discovered this both in animal models and human models of development. But basically, if you were to do TMS, transcranial magnetic stimulation, to provide a brief pulse to the motor cortex, and then measure the output of EMG in the hand muscles, you would get a motor evoked potential if the spot that you're on is basically situated over a point in the cortex that's connected to hand muscles. Okay? So basically resulting in motor evoked potential. So it turns out, this is the work from Janet Eyre in Newcastle, and if you stimulate the motor cortex in a newborn infant, basically you get a motor evoked potential in both hands. So that means that the motor cortex is connected bilaterally. Basically, this is the point of stimulation, and you get a sudden burst of EMG seen here. So basically, during development, that means that both sides are connected to both hands. Okay, bilateral connectivity. So during development, by 6 months, you begin to see a little bit of a asymmetry, so that you get a differential in the latency and the magnitude of the MEP between the two hands. And then by 12 months, even more so. And then finally, by 24 months, you largely get the contralateral motor evoked potentials that one might expect that you see in an adult. So you get basically this contralateral projections. Okay? So this isn't a typically developing healthy infant. So this was another study that she did where basically she looked at kids with hemiplegia, and what she found is that initially both the infarcted lesion side and the non-lesion side, just as in typically developing kids, you had bilateral activation. But by 6 months of age, you begin to lose that in the lesion hemisphere. And by 12 and by 24 months, basically there is no connectivity. So this is an example of a case where the lesion hemisphere no longer connects to hand muscles, and the non-lesion hemisphere takes over and has connections to both hands. Okay? And I would say, no one's actually studied this systematically, but in our experience, I would say about 40 to 50% of kids have this type of ipsilateral corticospinal tract connectivity pattern. Well, it turns out that this influences dexterity, as well as the integrity that I showed you. This is a child here who, again, you have the lesion, you provide stimulation, and you get a motor evoked potential contralaterally. This is another child with a different lesion, basically no motor evoked potential happening, and basically the other side will connect to the affected hand. So this is the box and blocks. So the greater number of blocks that are moved in 1 minute, the better the score, better the dexterity. So kids that maintain this contralateral pattern are generally more dexterous than kids that have this reorganization here, basically where one side controls both hands. And then there are some kids that both hemispheres connect to both hands, and they're a confusing group that nobody wants to look at, unfortunately. But they're probably somewhere in between. They're very, very heterogeneous. So the point is that this organization is probably functional, but it has an impact on the hand function as well, so that these kids tend to be less dexterous than kids that have maintained the normal development. Okay. So moving on, so it's not just impaired movement execution. We've demonstrated in a series of studies that they have impaired motor planning or anticipatory motor control. So this was a study we did 20 years ago. And basically we were looking at grasping forces as children grasped and lifted an object with their hand and held it up in the air. And they did this several successive times, so they would build up a representation of the object's texture and the object's weight and scale the forces to that object based upon that experience. So in the very first block, say after child 5 of a typically developing kid, these are 2 different weights. The solid line, sorry it's not as clear with the lights here, but basically you see they use higher forces for the heavier. This is basically a 600 gram object, a 400 gram object compared to a 200 gram object. And they have uni-peaked, single-peaked grip and load force profiles prior to the point of object movement here. So, and importantly, what you can see is that besides being single-peaked, the rate of force is higher for the lifting force and the grasping force for the heavier object. And again, this is prior to liftoff, and you have no feedback about an object's weight until it actually you generate enough force for it to move. So they're using prior experience or motor planning to scale the force to be higher for heavier objects. This is a child with CP, and basically what you can see is not these beautiful single-peaked force rates, but you see these very sequential, much slower increases in force, and importantly, there is no difference in the magnitude of the force rate for the 2 different weights. So we would say that they have no motor planning, no anticipatory control. And that's originally what we thought, and I'm going to come back to that. They also have bimanual control. This was a study done by a former postdoc in my lab. It's using this task, a drawer opening task, where the subject reaches towards the handle of a drawer, a spring-loaded drawer, with one hand, and then basically manipulates the contents with the other hand. So we look at the kinematics. So basically the dotted line here, reaching towards the drawer, this is the velocity, and then pulling the drawer open. And then this is the reaching hand to manipulate the object. So basically you can see the important thing is that very shortly after the hand reaches towards the handle, the other hand reaches towards the contents. This huge overlap of the movement, and then therefore the time between getting the drawer open and manipulating the contents is short. This is a child with CP. Extremely sequential. They reach towards the drawer, begin to pull it open, and then only then do they begin to initiate the movement towards the contents. And then the time, therefore, between opening and manipulation of those contents is long, and the movement time you can see is drastically affected. So bimanual control, spatial temporal control is affected. It turns out that bimanual performance is very closely related to, I should say moderately related, is probably a better term, is related to the integrity of the corpus callosum. So this was a diffusion sensor imaging study, basically where we quantify each of the 3 main areas of the corpus callosum and relate that to the performance of what's called the assisting hand assessment. It's a video-based observation and then rated by a blind evaluator, quantifying the quality of affected hand use during bimanual play activity. Okay, so the higher score, the better. And you can see basically that the number of fibers is correlated with the proficiency on this measure. You can see that the FA values, basically integrity, also is correlated to moderately. And then basically the number of streamlines is related to goal synchrony. So goal synchrony is the time in this kinematic task between opening the drawer and getting the hand, inside the contents. So the kinematic, it relates to the kinematics of the task. So basically, we can show a relationship between the integrity in both with a clinical test, but also quantitative kinematic, looking at biomechanics test of bimanual control. I'm not going to go into detail, but a recent postdoc that recently just began his a new assistant professorship at Boston University has been working with us on basically parcelizing the brain into a number of different regions using kind of a motor learning, a learning algorithm, and basically looking at the differences between the size of each of these areas in typically developing kids and kids with CP, as well as different types of lesions, basically a middle cerebral artery lesion versus periventricular infarct. And basically, I think that even though we think of the system as being only related to the damage of whatever the lesion is, it turns out that more than 93 areas were identified as being affected. There's an asymmetry between the right and left side of the lesion and non-lesion side. The important thing that maybe we found, and this is a lesson for the students, we did a study in Sweden back in the early 90s of kids 6 to 8 years of age, and we looked at their motor control of the hand. And 13 years later, another person who was involved in the study, a student at the time with me, and I were at a conference, and we were in a bar, and basically we got into an argument about whether CP really is static and whether hand function can change. And I came up with a silly suggestion. It's like, what's the chance you could find, the kids that participated 13 years ago? She's like, oh yeah, Sweden, like, their personal social security equivalents means we can track anybody anywhere. And she did. She actually was able to track the majority of participants who are now between the ages of 19 and 21 years. And this is the Jepson-Taylor tested hand function. So in this case, it's just a timed battery of how quickly you can manipulate a bunch of different objects. So the faster the time, the better. These are the individuals with CP at age 6 to 8 years, and basically at the age of 19 to 21, every single child showed an improvement in their hand function throughout all types of therapies, surgeries, pharmaceutical treatment, and or no treatment whatsoever. And it turns out that, okay, so this is the mean improvement. This is the mean of age-matched typically developing children. So what it means is that they're paralleling the development of their typically developing peers. So that means that development happens. It happens at the same rate, but you're not changing the offset, unfortunately. So the key to rehab, of course, is to try to change that offset to get closer to their typically developing peers. But importantly, it means it's not static. And it turns out that it improves with practice. And this was an unexpected finding that we had when we did these grasping tasks in the lab, so measuring fingertip forces. We actually followed them for 25 lifts. So within 5 lifts, the typically developing kids, actually within 1 to 2 lifts, typically developing kids have gotten this motor planning down, none whatsoever in the kids with CP. After 25 lifts, well, the typically developing kids look pretty much the same as they already did. But now you see a much improved motor behavior. The lifts are faster. You see the rates of force increase are higher. And importantly, you can see that the rate of increase for the heavier object is now reflecting that weight. So that means that they've now learned the properties of the object and are able to scale the forces accordingly. So it took them much longer, and that means that they have impairments in motor learning. And that's an important finding to us because it means we need to think about the motor skill itself being influenced by a triad of factors. One being the person and the various constraints that they have. The second being the task that you provide, that you ask them to perform. And the third being the environment. So the fact that basically learning or relearning is influenced by these 3 different factors means that there can't be a one-size-fits-all approach to rehabilitation. Because each person's going to basically have different constraints, be able to perform different tasks, and you'll have to modify the environment to basically allow success or, basically to change the movement patterns themselves. So this means that it's important to understand the characteristics of motor skills that influence this process. And this is where I was joking with the title, but it's this understanding of motor learning and control mechanisms that allow you to target these sorts of deficits that becomes very important. So my former colleague at Columbia, Anne Gentile, was very influential in the field of motor learning. Basically, she pointed out that the behavior that dominates our daily life is basically aimed towards goals or function. And her controversial idea, and she was a physical educator, and basically her controversial idea at that time focused towards coaches and physical ed teachers, was that you can't teach the same pattern to each individual, even a typically developing child, because what works for one individual is not going to work for another. And the reality is that the brain, the brain, especially in an individual who has neurological or physical constraints, is going to choose a pattern actually that's optimal for them. So then, historically, we get therapists that have come along and said, well, that's not working, they're not doing this normal, and they try to change the movement to be normal, and it looks better, but it isn't what they chose because it isn't necessarily as optimal based upon their constraints. So her idea was that you use the environment and use the task to shape effectively the motor performance that you want to match what you're trying to get at. So establish the goal, set up the environment, and then let them practice. So it's problem solving. It's a very, very active process, putting a lot of the reliance on the child or patient. And then, Lutash pointed out in a similar way on an important paper more than 20 years ago that basically changed motor patterns should not be considered pathological, but effectively adaptive. And that fits along the same idea, that they adapt to what they are able to do. And then two students of Anne Gentile's from Australia basically took some of these principles and created, or turned this task-oriented training for stroke patients, or effectively what became known as motor learning based intervention. It involved basically the idea that rehabilitation involves motor learning. So therapists basically are increasingly aware that these infants and children are active participants rather than passive recipients. So Jim Gordon, he was also a student of Anne Gentile. He's been the chair of biokinesiology at USC for many years. He's been a great translator of knowledge and very thoughtful on this topic as well. So he kind of asked the question, well, what is motor learning approach to therapy? And I can't tell you the number of papers that I come across where people use that term, but then in no way go on to either to describe it, or what do they mean by it, or what they describe actually isn't consistent with what at least I conceptualize it to be. So Jim basically said one option is that you can define this approach as the idea that you use motor learning principles to form a set of rules or guidelines, and then we use these principles and the best available evidence about how people learn motor skills to enhance the effectiveness of practice. So I think this is great. The problem is twofold. One is we know very little about how people learn motor skills. And second, what we do know largely is in typically developing adults in laboratory-based tasks. Okay? And I was at a meeting, I think summer 2018 at Penn State, where Mark Latash, after 2 days of people presenting clinical motor control, kind of stood up and said, everybody's doing garbage because you can't understand rehabilitation unless you understand how the brain controls movement, and we're nowhere near there. I'm not nearly as skeptical as that, but I think he's right that you do need to understand principles of motor learning and control in order to optimize therapy. So there might be some problems with this idea. The other is that the motor learning process itself is the therapy. So it's the process of engaging and kind of driving plasticity with motor learning. So basically, they're not merely rules, but they're more of a toolbox that you can provide to the individual. And the therapist engages in a dialogue with the patient to select the tasks and the environment that will maximize their recovery. So I tend to think of it more as the latter. Nonetheless, what we do know about this, of course, needs to influence, the way that you provide the practice. Okay. So, the other factor that I mentioned, besides active motor learning-based approach, is intensity of training. So, typical therapy sessions are 30 to 45 minutes. Not a whole lot of training can happen in that time period. So, my friend, colleague, Karen Adolph at NYU, studies infant development. She actually did this clever study where she actually characterized from the very first successful step that a toddler took, age 12, 14 months or so, to the point where they become adept walkers, where they don't fall anymore. So basically what she discovered is that on average they took 14,000 steps a day, okay? 46 football fields, and they fell a whole lot. So when you think about helicopter parenting, maybe the falling actually is an important part of that problem solving. Approximately 1 million steps happened by the time they actually became proficient walkers. So Catherine Lang, I think you mentioned, is coming in
Last week of, second week of December.
Second week of December, okay, coming up soon enough. So she did this cool study in adult stroke rehab where she characterized the number of repetitions in therapy for adult stroke patients who claimed that they were doing motor learning-based therapy. And she showed that basically for the upper extremity, the typical number of reaches or grasps were around 32, okay, in a typical session. And for people focusing on the lower extremity, it was about 357 steps. So the important thing is, like, you can see this huge dichotomy, right? Therapists' hands are tied because our health insurance doesn't provide, the opportunity to get the sufficient number of practice and therapeutic sessions. So when we found this motor learning, this idea that the kids learn, but they need intensity, we went back and we, systematically went through the literature, and basically we found lots of animal studies starting already with Sherrington more than a century ago, and then psychologists doing kind of psychological work on shaping, modifying the environment and the task to get successive approximation of behaviors, lesion studies of pyramidal and sensory tracts, and then more importantly, the more recent neuroplasticity work showing basically changes in motor cortical representations with various forms of training. And then at this time, basically we're talking late 90s, we also found the adult stroke models. So Steve Wolf at Emory basically had done the first studies of forced use in adult strokes with hemiparesis. So forced use is they take the good hand or upper extremity, they put it into a sling, and they send the adults home, and forcing them to use their affected upper extremity. Okay, so it's kind of passive practice. Taub at Alabama subsequently added an active training component, kind of adding a lot of the shaping components here in intensive practice, where basically it became much more active, where it's therapist-guided training happening. And actually, it turns out that the first multi-site trial in physical rehabilitation was performed by Steve Wolf and Taub back just 13 years ago. They finished. It's called the EXCITE trial, where they demonstrate that a large proportion of subjects, basically with adult stroke, can benefit from this constraint-induced movement therapy. And then there are lots of reviews and many, many studies since. So back in the late 90s, we worked with Steve Wolf to modify this approach to be child-friendly. So basically, we went and we performed a case study series initially where we went to the homes of kids in New York with CP, and we, for 6 hours a day, put them into a cotton sling and engaged them in motor activities to get them to use the upper extremity in very much the same ways that was done in adults, but focusing largely on play. Okay? Play, reaching, grasping activities in the context of play. And we had very successful, promising results, I should say. So since that was the first study of constraint therapy, and you can see that the number of studies has, boomed. There's more than 100. This is, I guess, stopped in 2014 counting because it just became too onerous. But basically, even now there's more than 100 studies, with more than 30 of them being some form of a randomized controlled trial, pretty much all showing that constraint-induced movement therapy is beneficial for a large number of individuals with hemiparesis, CP. So the problem that we found is that, so we followed that up and we did some small randomized control trials. Obviously many others, did these randomized trials. But even before the evidence was out, there were many clinicians, especially physicians, who read this work and they got the wrong idea. They thought, oh, well, if we just put the good arm of a kid with CP in a cast and send him home, that's going to make them better. Okay? So, well, a cast is pretty invasive. It's big, they're heavy, you can't do anything with it. And importantly, you send a kid home like that without modifying the environment, they're not going to be able to do very much. They're going to be frustrated. There's a relatively huge dropout of some of those studies that have used that approach. And basically, I personally feel like that's an invasive way of performing this. So we kind of felt compelled to ask the question of, do you even need the restraint, or is it simply just figuring out clever ways of getting the kids to use their affected upper extremity? So we took bimanual training, which was one common tool in physical and occupational therapy. We intensified it to the same levels of constraint therapy. I didn't mention, so constraint therapy typically is done for 2 to 3 weeks, at least 6 hours a day. So 60 to 90 hours, so very, very high intensity. We did the same thing with bimanual training, and we structured it in the same way, providing shaping of the environment, part and whole practice, progressive structuring of the progressive increase of motor difficulty as the kid becomes successful, but all in the context of play and function. So the first we published a study to showing that compared to regular ongoing therapy, you get much better improvements, largely because of the intensity. But then we were compelled to do a trial. So this is a small trial of 42 kids with hemiplegia that were randomized to either the hand-on bimanual intensive therapy or constraint therapy. So basically the red is the bimanual training, blue is the constraint therapy. This is the time on the Jackson-Taylor, the battery of dexterity test. And you get an improvement from pre to post-test, and then this improvement is maintained over the 6 months that we followed the kids, after that initial 90 hours. So these are kids between the ages of 4 and 13 years of age. So the improvement was statistically similar between the two groups, and we get the improvement in dexterity is about 30%. Okay, so the slide that I showed you of the improvement that occurred over 13 years, on average, it was 15%. We're getting a 30% improvement in 3 weeks. So I think it's fairly powerful, and as I'll point out later, they're additive. You can do it again, and you'll get improvements again, and we don't really know what the ceiling is. It doesn't cure them, but basically it progressively improves their dexterity. The assisting hand assessment, looking at bimanual control or bimanual performance, same thing. Both groups improve, and this improvement is maintained over the 6 months that we follow the kids. So it turns out it's not quite as simple as that they're the same. So we asked parents to identify goals and then to rate those goals in terms of success. It turns out about 85% of those goals are bimanual because they have a dominant good hand. And basically, the kids in the bimanual, both groups improve on their goal performance as perceived by parents, but the kids in the bimanual training group improved more. Not terribly shocking because they could actually practice those skills during the activity. The drawer task that I showed you, it turns out that both groups improved. They never practiced this task during these camps, but basically you get an improvement in the overlap. So a typical adult would have about 80% of the time the two hands would be moving simultaneously. They start off at about 25% of the time, as I showed you earlier. you get an improvement in the constraint, but you get basically a much bigger improvement in the bimanual training group. So when you get down to the nitty-gritty of motor control strategies that you can only determine with biomechanics, you start to see some specificity in the training approaches here. Okay. So we've done lots of studies since 2002. So we went from that initial in-the-home to day camp model. The reason being that New York homes are spread out. We don't typically have cars, and the homes can range from a regular-sized, home in the suburb to a one-room apartment with 6 kids, literally, and from highly enriched to greatly impoverished. So we decided we needed to standardize the approach. We needed to bring people into our labs to create, day camp models, and then also the social interactions would be a fun, motivating way to experience this. So we've done 32 of these camps since 2002 with more than 300 kids, starting at age 2 for home programs up to age 17, many of them repeating. We've shown that, as I showed you clinically, both approaches result in clinical improvements, but habit improves functional goal performance and bimanual coordination. The benefits are seen across all the ages of the participants that we've seen. Generally equally, but I wouldn't say that the mechanism is the same because older kids, and especially teens, become much more concentrated. You get a much greater number of repetitions per unit time. They are goal-focused in many cases, so basically they work harder. And then if you repeat the dose of these, basically you continue to get improvement. So it's not a magic, this is just practice, right? We give more practice and they get better, and we don't know the dosage or intervals, but basically it's a way of structuring practice. So the next question was, what about ingredients? So we manipulated ingredients focusing on skill progression. Okay? So we know that newly learned movements in animal models basically are represented in larger cortical areas than previously existing movements. Repetition or rote behaviors don't drive neuroplasticity in rat models. Basically, it's the motor skill acquisition or motor learning is required. My colleague Kathleen Friel and Jack Martin created a feline model of CP and even a constraint model where they created lesions by injecting GABA agonist into the motor cortex of a developing feline cat, and basically results in paralysis, and then they basically strap the other arm up, and then they either perform passive or active training, and it turns out that the active training with skill progression drove neuroplasticity of the developing nervous system, much more so than just the passive restraint. Okay, so active control. So the idea is that we took a small trial of 22 kids, aged 6 to 14, and we had a structured practice group, habit as I've described, where we had skill progression and shaping and all the ingredients that so far we believe to be successful. And then we had as a control group an unstructured practice group, and that's performing the same activities, but never asking them to increase the difficulty or perform it in any other way, just perform it the way that they normally do. And we asked the people working with them, the interventionists, never to make it more difficult. They were kind of blinded to the idea that there was another group. And we told them, this is a play camp, it's just recreational. Do not in any way stress them out because they get lots of therapy in school. They don't, but we don't know. So basically, day camp environment, both groups are 6 hours a day, and the evaluators and interventionists are blinded to the existence of the other groups. So it turns out, again, if you go to simply the bimanual control or the manual dexterity, both groups actually prove similar. So maybe it's such a high intensity of 90 hours of training, all this overthinking and motor learning, maybe it doesn't matter. But it turns out that the group receiving the structured practice improved more on perception of goals, because basically goals involve motor learning, and we couldn't do goal training with the unstructured practice group. So practice goals, you improve on goals. Again, not terribly interesting. But biomechanics, again, basically, shows you the contribution of the trunk to the reaching motion towards the draw. the unstructured practice group had about a 10 centimeter contribution of the trunk when reaching just 75% of arm's length. And they didn't change over the course of practice. The structured practice group basically increased their elbow extension and decreased their trunk flexion towards that action. So again, biomechanics begins to show a different picture. And I think that this is important as, movement scientists in this room about the possible contributions that we have, not just for providing knowledge to rehabilitation, but the ways that we can test in a very careful way. So elbow exertion basically is what's driving this. So biomechanics can show this. Okay. So these kids all underwent transcranial magnetic stimulation, where basically, again, providing a pulse to the child's head. It's co-aligned or with neuronavigation to the child's own MRI. And basically, single pulses we record in the digit wrist and bicep muscles bilaterally, and we map basically using the 110% of pre-training motor thresholds, both in pre and post training. So we always use the same intensity of the stimulus that's specific to that child. So this isn't showing up so well in the light here, fortunately, but the important thing that to notice is that, so this is the structured practice group. So each circle here represents the representation where we found a motor evoked potential. A red is digit, and the green is the wrist, and basically in black is the bicep. Sorry, black is there's no connectivity. So the important thing is that you see just a little bit here. You see many more, especially red dots, digit, and over 6 months, basically this is maintained. In the unstructured practice group, systematically there was no change in the overall size and the intensity, as I'll show you. So this basically is the map size, number of sites that are in the area that is stimulated. So we get an increase from pre to post test that's maintained with structured practice, but unstructured systematically you do not. And then the percent change in the, so the percent change basically is much greater and is again maintained over that 6-month post test. So greater neuroplasticity that's associated with this training. And it turns out that it's specific, if the representation was on one side of the brain before, like the ipsilateral connectivity, that's where you saw the changes. And if it was contralateral, that's where you saw the changes. We never saw a kid suddenly becoming contralateral if they were ipsilateral previously. So we also see changes in the motor evoked potential. So the more, basically, red means higher intensity of these motor evoked potentials. So you see more red here in the pre and the post test, and no changes systematically in the for the unstructured practice. This shows you that it's true for all the kids that we tested. So going on, so how does this influence rehabilitation? So 10 years ago, a group in Germany, Martin Stout, did a study looking at the connectivity pattern of the corticospinal tract in relationship to outcomes of constraint-induced therapy in a small group of children. And they found the time component of the Wolf motor function test, which is really just the Jepson test that I've been talking about. The kids that had this contralateral projections here had an improvement. The kids that had this ipsilateral, not only were they more severely affected, but they actually got worse. And that means that, constraint therapy may not be the best approach for that group, okay? We were somewhat skeptical of this finding for a main reason. We had not, up until this point, been doing TMS on kids to determine their motor patterns, but we see lots of kids that have mirror movements. If they move one hand, the other hand follows. That means minimally that they have bilateral connectivity, and in many cases would have ipsilateral connectivity, and they improve as well. So the first thing we did is, so basically the idea is that when you have this contralateral projections, you also have interhemispheric inhibition between one hemisphere to another, and that might actually be there might be an over-inhibition in kids with, who maintain this connectivity pattern versus that wouldn't happen in this group, and they just had one hand that controls both of these. So we retrospectively brought back 36 kids who had undergone bimanual training, and we mapped out their motor cortical representation, so the corticospinal tract connectivity patterns. And it turns out that kids that had ipsilateral patterns and contralateral patterns had improvements on the Jepson-Taylor dexterity test. They also, both groups had improvements on the assisting hand assessment. Okay? So that means that at least bimanual training doesn't have that same potential problem that you see in the constraint therapy. So we kind of leveraged this. We got an R01 a number of years back to do a larger trial, and we just finished this. Actually, it says currently, but basically we just finished the 6-month collection in February on these kids, where basically to test the relative efficacy of constraint and bimanual training depending upon the corticospinal tract organization. So you were among the first to see these results, and we still need to tease these out further, but basically, so red is contralateral, blue is ipsilateral, and this is constraint on the left here and habit on the right. This is for the Jackson-Taylor, so basically you get similar improvements in both groups statistically, and likewise on the assisting hand assessment, both groups improve. So the bad news is it's a negative finding that both groups improve similar. The good news is maybe it doesn't really matter, it's not the corticospinal tract that determines efficacy. And I was at a recent conference where we were asked to talk about biomarkers for hand improvement and what are they and should they exist, and maybe we could come up with a gene test, to determine, which is possible. But then, the question would become, do we really want a biomarker per se, because that might be used to determine who gets therapy. And the reality is there are many, many kids who, if you look at the neurological damage or look at anything that could be the biomarker that we could tell, they basically might say they'll never learn to walk, and they learn to walk. Okay? So I don't think it's just biology that is going to influence. I think it's the environment and driving and how much therapy and parents and everything else and the kids' motivation and so forth that improves function. Just very quickly, I know we're running time here. Importantly, even in hemiplegia, no work had shown efficacy focusing on the lower extremity systematically. When you get to bilateral CP, there's no work even that showed upper and lower extremity control, improves, be recommended into clinical practice. So, a couple of colleagues from Belgium and the Netherlands, Jannik Leenhoff and Eugene Ramakers, and a graduate student in my lab, we worked on modifying hand-on bimanual therapy to include the lower extremity. We call it habitio, including the lower extremity. So basically, it's performing many of the same manual activities, but in many cases, it's performed with lots of gross motor activities, and even when they're performing manual activities at a tabletop, we would require them to sort of balance their trunk and kind of stabilize themselves on a fitness ball. In the context of games, they might do a lot of standing activities, but they're always stimulating both the upper and lower extremities. And in this case, importantly, it's in bilateral CP, which is a more severe form that very little work has been done. So this is simply a clinical test called the gross motor function measure. So the higher the score, the better. Kids that receive this training, again, 90 hours in a day camp environment, statistically improved more than a group that received the typical ongoing therapy, in this case, Belgium. This is a pediatric balance scale, same thing, improvements for the habitio group, no improvement for the ongoing therapy. 6-minute walk test, same, and basically a questionnaire about locomotor function, the same thing. So basically, you can drive lower extremity training. So I'm just going to show you 2 videos. Oops, if I can get a mouse here. Screen behind you. Okay, this is a 13-year-old girl with diplegia. And she is typically a wheelchair user. She can't go to the bathroom by herself, even in the house. She needs a wall for support, and she needs somebody behind her to spot if she's very insecure. Okay, very slow walker, but she can walk. Okay, 3 weeks of training. Oops. She can walk. Okay, she's not using the wall for support. She's still afraid. It's only been 3 weeks, so she wants someone behind her to spot her. It's not pretty. She has orthopedic issues. She's probably going to need some spasticity management, some orthopedic surgery, but nonetheless, she can go to the bathroom by herself. She can go to the refrigerator. She can do some small, daily things that influence her daily life. I just want to point out, so we've been doing some robotic training with a group at Columbia, Sunil Agrawal. Trunk control is a big factor for these individuals. So we created using a tethered belt system here that are connected to force transducers, and basically the body is monitored with a Vicon system. We created what's called the trunk supported trainer, or TRUST, where we can look at the boundary of stability of independent sitting. So basically, the idea is that we put individuals into this, have them seated, provide effectively a force field around them. So as they move forward, when they get to the point of instability, it'll use about 10% of body weight force to pull them back towards the stable seated position. And then we train them with reaching and grasping and kind of fun play activities that force them to get outside their boundary, where they become unstable. And this basically will hold them and then pull them back towards the center. So we progressively challenge them by, in this case, changing the size of the circle as they get better, making it wider. We can change the amount of force. We haven't done that yet. Reduce it, for example. And we can change the level. We adjust the level of support here based upon a clinical measure called Seated Assessment of Trunk Control, or SATCO. So once they get proficient at a certain level, segmental level, you can decrease it. So basically they have more of their body segments to control. And we have run 3 individuals so far with CT. So this is pre-training in white, superimposed into these plots for one individual. So basically, what this is a reaching test where they have to reach as far as they can towards an object in each direction, and we look at the point where they fail, to support themselves. So this is effectively the area of stable seating. This is after 6 training sessions, the gray here, and then after 12 training sessions, we bring them back a month later, and then 3 months later. So what you can see is that there's more gray. They basically have increased the area, the boundaries that they are able to control their seating. This is another subject and a third subject here. So in all 3 cases, this suggests it's a promising approach, and we're in the process of figuring out the appropriate control for this, and then getting some pilot data and applying for funding for this. Okay. A big problem, approaches that I've shown you that work, 60 or 90 hours of training. It's like 1 to 1.5 years of therapy compressed into 3 weeks. There are not many sites in the country. I think there actually is one in Denver, does constraint therapy, but pretty much it's not affordable for the healthcare system to manage in most cases. So even if it works, it's not implemented. So we need to figure out how can we compress that into a shorter time. So one potentially promising area is to stimulate the brain on the sites that basically are controlling the affected hand, determined by the TMS, and basically seeing if we can, using TC stimulation, temporal TC stimulation, and basically stimulating those sites in a very individualized to each person, and seeing if we can improve the motor function when it's combined with just 2 hours of training for 5 days, so 10 hours total. And we have just received a renewal of that grant that supported the trial, we're going to be doing this to see if that works starting in December. So far we've run 25 kids, and I can tell you it looks promising, but we don't have enough power to be able to distinguish between the various types of stimulation and control groups, sham stimulation or physical training alone. So, to wrap it up. So basically, the approaches that capitalize on motor learning principles and control, basically involving active movement, are effective in improving movement coordination and function. Intensive training is necessary, but intensity alone, as I showed you, for example, in the control group that was done in Belgium, isn't sufficient. Okay, you need to have the right ingredients. Skill training, progression, is improving goal achievement and motor coordination and enhancing motor plasticity in the motor cortex. So that kind of parallels animal models of neuroplasticity. Motor learning approaches can be successfully applied to the lower extremities and include, showing promise for kids with more severe forms of CP. And then, importantly, biomechanics is a very powerful tool that we can use to both, kind of drive the rehabilitation. Even the robotic training that I'm showing you is driven by, kinematics and forces applying kinetics, basically that individual is we're using, and then basically for detecting changes, outcome measures. Okay, so a key issue is then leveraging these findings to enhance motor learning and reorganization, which we are currently working on. We have a large number of students and postdocs in the lab and collaborators that have passed through this, and this is just a handful that the work couldn't be done without them. Many of them are physical or occupational therapists or physicians, and it's really an engineer, so it's really a multi-disciplinary approach, and I think that's what's going to be needed in the future. Thank you.
Maybe time for a couple of questions.
You spent a fair bit of time talking about the variability in motor impairment that folks with CP have, and maybe diplegic and hemiplegic. They also have a wide variety of cognitive impairments. I wonder if you would talk a little bit about how that may or may not impact their ability to go through these motor learning paradigms, set goals. Do you think that's a substantial predictor of how well they're going to do right off the bat?
So, I have to admit that, for the simplicity of, trying to figure out these ingredients, that we include higher functioning individuals. And one of the inclusion criteria is that they're maintained in schools at their age appropriate level. So academically, I can't say that they're normal, but at least they're, they're in the same target range. The problem comes that the impairments are going to be more subtle. You need cognitive tests, not just intelligence, but lots of different tests, especially motor planning tests that really kind of get at what their specific problems are. I think that ultimately it needs to be individualized based upon what you're seeing for each person, and you need to come up with new strategies to get people that are not problem solving themselves to be able to do these tasks. Yeah, I think that's the main issue. I guess a problem that I would see with it is, it's the testing. To really figure that out, you'd have to do large batteries. And, I didn't mention, but CMS takes 6 hours. Well, it's 2 hours per session. We do 2 sessions pre-test and post-test at 6 months. They get a 1 hour MRI, they get 1 hour of hand training, and then they do a couple of other hand assessments, and then a couple of simple tests. So it was like 6 hours. So we wanted to get into cognition.
Add a couple more hours in there.
Yeah. Family burden is the main concern. But I think it is an important point. I think that ultimately we need to be able to get to kids that have cognitive problems as well. We are in the process, so we're not doing cognition per se, but we also, I didn't talk about, we study something called participation. Okay? Participation is, kind of the concept is, not just what their motor control is like, but how do they actually integrate society and create, whole meaningful lives, and it's done through surveys. An important aspect of that is engagement. Basically, not just doing an activity, but engaging with a person or being fully immersed into that activity. So we've been doing some surveys of the kids, of the interventionists, of the testers during the evaluations, of supervisors in rooms, and parents about the kids' engagement during various activities. And now we are using video coding, using data view, to code basically a number of behaviors that happen during some standardized tests during the camp that hopefully will correlate with engagement, and we're relating those to pre-post changes. And if you were to ask me, I would say that it's the extent to which the child is engaged and immersed in the task and relating to the individual that they're working with is probably the biggest factor beyond any of these neurophysiological ones. And that relates to cognition and behavioral kinds of things as well, attention and things. Yes?
Music.
We do not use music in therapy per se. So at the end of each day, so much of the time they spend one-on-one with their interventionist, which is why it's expensive. Sometimes we pair them so that they can play games together. But at the end of each day, we want them leaving, happy and motivated. Hear parents, have the parents come and hear them all like happy. So music would be an activity that we might perform with them, where each kid gets an instrument, and then or sometimes if the child's goal is to learn piano or maybe start the guitar, that might be an individual activity that they get, but we don't systematically do that.
I guess I was just thinking about one of your opening lines was the sensory issue as well.
Yeah.
So given the plasticity of the brain,
Yep.
can you accommodate or compensate for some of that lack of sensory with audio?
Yeah, probably, and I think that, we're targeting the motor system, but the sensory system is probably contributing a whole lot, to the impairments. We also have a grant that's focusing on figuring out exactly what those contributions are to the motor impairments in these kids using brain diffuser tensor imaging and TMS and a variety of clinical tests. But yeah, anything that's going to increase the enrichment is going to have a positive effect. Yeah. So some kids, so in the bilateral activities, sometimes we'll do group dancing, for example, to music, and or even some rap stuff and things that are age appropriate.
Great. Thank you.